Okay, thank you for this presentation, Bassem. So my second talk is the one I was supposed to do to the AAOS in September, but it was not possible for me to come. And it is my first official presentation of this paper. And the question was, is it tendon transfer, is it the only way? And it was a battle between Europe and USA. That means a battle between SCR versus tendon transfer. Because a lot of questions we have is what are the indications of SCR. So I will talk about my personal experience. If you come back to this very old paper, the shoulder biomechanic, of course it's evident, but we forgot that. You have the starter of the shoulder, the deltoid, the pec major, and especially the clavicle head. On the opposite, you have the stabilizers of the shoulder with the supra, the infra, and the subscap. At this time, we did not talk about the teres minor, but it's very important too. So what happens if you have no deltoid? We can ask to Bassem. No deltoid means the patient is normal, and he has normal active range of motion because the joint is stable enough. You don't have to propose anything to this patient. We can operate, but no treatment is really needed for this patient. On the opposite, what can happen if you have no cuff? So we have a good deltoid, but no cuff. No cuff, as you know now, may lead to loss of active range of motion in one or two directions, and it can lead to an unstable shoulder, and we call this the superior escape, and we know now we have a posterior superior escape or the anterior and superior escape, which is with more consequences. In that situation, you have to propose a treatment, and first you have to make a dynamic transfer, and second, if needed, you have to stabilize the shoulder, because a tendon transfer alone cannot stabilize the shoulder. So, if I come back to my first video, the PLEA, you remember the painful loss of elevation active, maybe what you call the cerebroparesis. In that situation, you can propose a partial repair. Yes, of course, I did it. But what next when it doesn't work? Because sometimes it doesn't work. So you do a second partial repair, you cut the biceps a second time. Pascal told me, just cut the biceps a second time. So a balloon, look at the balloon after 1 month on my furniture. The balloon has no any mechanical effect after 1 month. It's totally dry. I cannot understand how it can work after 1 month. So you can make an SCR, yes, but it's a static stabilizer of the shoulder. It's not a dynamic. So maybe it can help the shoulder, but it cannot recreate a movement. The reverse, but of course, what happens if a patient is very young? So for that situation, look at the type D of Philip Collins, supra and infra, two tendons. The best transfer for me is the lat dorsi, and now I will show you, I propose the double combined transfer, lat dorsi plus teres major transfer. In the Eiler, you remember the deficit of isolated loss of external rotation. You can propose a partial repair, but you have a fat infiltration type 3 of your infraspinatus. You can repair the tendon, but why? Because you have no muscle belly behind. Look at the balloon, look at this video. After 1 month, you take the balloon, it doesn't work. So I cannot understand after 1 month you have no balloon, how it can work after 3 months or 1 year. You talk me about the SCR. Yes, but where do you fix the posterior SCR? When you listen Burkhardt and you listen all the surgeons who propose SCR, they have to fix to the glenoid and to the anterior, to the posterior part of the cuff, remnant cuff, and to the footprint of the supraspinatus. But you have no posterior cuff. You cannot fix to the back. So why do you fix it? And reverse, but the reverse, you know, cannot recreate active rotations. For this, as I told you, I follow Bassem. The best transfer for this is the lower trapezius transfer. We know it is the best one. It is stronger and more efficient than the lat dorsi transfer. So now the deficit of internal rotation, exactly the same discussion, a partial repair, yes, if it works, but what if it doesn't work? And what about if you have a fat infiltration type 3 or 4 of your subscap? It's totally useless for me to try to repair. You may stabilize the shoulder, but you will not recreate internal active rotation. You know what I think about the balloon? And what about the SCR? If you have no subscap, where will you fix your SCR? For me, it's difficult to understand that. And because of that, active reverse is the same discussion regarding the age. Bassem have shown you, and I agree with him, it is the lat dorsi transfer, but anterior onto the footprint of a subscap. This is the best indication. So just, if you have time, this is a small movie regarding the full arthroscopic and combined latissimus dorsi transfer. If you have no time, I can cut this movie. Mr. Moderator, we have time to look at this movie? Yes? Okay.
Of course, yes, we have.
Okay, so this is the lat dorsi, and so I cut the lat dorsi anteriorly, and just behind the lat dorsi, you will have a teres major. And now, as I told you, I take it together, it's easier. You can see the three sisters, and on the left of your screen, it is the three sisters. This is the upper part of the teres major, and you see the axillary nerve just here, and the axillary, the circumflex artery. Then you have to release, and you will reach the long head, the triceps, just here, and take care. This is the distal part of the three sister, and then from the back, you take your loop, and you are into and through the triangular space. You take from the back, and you pull now posteriorly your double transfer, and you fix it very simply onto the upper part of the footprint of you will see. This is a big chair, yes. I have a better movie. My next talk is about just the technique. Sorry for it. I would like to show my results. This is my experience of full arthroscopic combined double transfer since January 2018, 3 years ago. I've made 107 procedures. You can hear my follow-up. And this is very important. 55% of my patients had been operated on previously. So they had no biceps, and they had a partial repair with a retear. They still have some pain, and I think it's a good indication for lat dorsi. This is my clinical results with a constant score, the gain, SSV, VAS, SST, so we have improvement of all the score. You can see the details of a constant score, and one point is the active range of motion, what is the gain, and especially active EA1, you can see I can improve an average of plus 22 degrees with the lat dorsi, but with the lower trapezius, it's more than 50. So if you want to recreate external rotation, the lower trapezius is better than the lat dorsi. So now, what about my complications? You see on the first column, the full arthroscopic combined transfer, and on the right one, the arthroscopic assisted mini-open technique. And you can see that in the full arthroscopic, we have no hematoma, no infection. It's not the same for the open procedure. And this is a big deal. On the opposite, I have 4 nerve lesions, but they were transitory. They recovered everything, and it was at the very beginning of my procedure, probably because I did not understand exactly where were the triangular space and the quadrangular space. It's very important to understand this difference. Finally, only one revision to reverse for the full arthroscopic combined technique, and lots of revision with the assisted one. So in conclusion, you can see that 9% of complication with the full arthroscopic technique versus 22% of complication with the open technique. Not open, but mini-open technique. And now how to get it better? Now I propose to make a lat dorsi transfer plus SCR with the long head of biceps. We call this biologic. So why is this my evolution if I still have a bicep? The tendon transfer can restore active range of motion, but the SCR with a biceps, not with an artificial graft, can stabilize the shoulder, and both together maybe can be push the limit of the indication. And this is my way since 2020. So in conclusion, you have these 3 situations, and sorry, it doesn't work very well. So you have either only one direction. You can make a tendon transfer, and if the shoulder is stable, you just can make a tendon transfer, ILE, ILE, and ply. This is the isolated tendon transfer. So sorry, it doesn't work very well. It's not. Okay. I think, and you have two directions. If your shoulder is unstable, for me, you have to make a reverse plus or minus a tendon transfer. This is what you have to remember today. Okay, thank you very much, Bassem. I think it's for you now.